Bismillahirrahmanirrahim. Today is the second series of the lectures of surgery. Today our topic is choledocholithiasis. This is a sequel of cholelithiasis. The outline of our lecture today is definition of choledocholithiasis, the types of it, clinical manifestations, diagnosis, and management. Choledocholithiasis is the presence of stone in the biliary tract starting from the hepatic duct to the common bile duct. You can see here that there are two hepatic ducts, right and left. They join to form common hepatic duct, and after joining the cystic duct, it becomes the common bile duct. So stone anywhere in these ducts is called choledocholithiasis, and just to remind you, stone in the gallbladder are called cholelithiasis. So again, choledocholithiasis can be stone in the biliary tracts. When they can be divided into extrahepatic and intrahepatic. The extrahepatic are in the common hepatic duct or the bile duct. Intrahepatic are proximal to the confluence of both hepatic ducts. Any stone present in the biliary tract of the intrahepatic part will be called intrahepatic choledocholithiasis. And the other way which we can classify them are primary choledocholithiasis. These are the stones which arise in the bile ducts de novo, and they are associated with biliary stasis, infection, and they are commonly brown and pigment stone. The secondary choledocholithiasis are the stones which migrate from the gallstones. As we can see here that they can be primary or secondary. The primary ones are extrahepatic or intrahepatic. Now coming to the presentation of choledocholithiasis, they can present by recurrent bouts of biliary colic and intermittent jaundice, only jaundice, and they can present as acute cholangitis, which presents in a triad of symptoms called Charcot's triad or pancreatitis, or sometimes choledocholithiasis presents after cholecystectomy as recurrent stones, which we will discuss later. The clinical indicators or likelihood for choledocholithiasis have been divided into three. It's very strong likelihood of choledocholithiasis when you can see the stone on the transabdominal scan, or there is evidence of clinical ascending cholangitis, or the bilirubin is high. And when only two of them are present, that's dilated CBD, only the common bile duct is dilated, no stone is seen, and bilirubin is higher side, then it is called strong likelihood. The likelihood will be moderate when there are abnormalities on liver function tests and the patient has pancreatitis. So whenever we are going to diagnose, we have to keep in mind these clinical indicators for likelihood of choledocholithiasis. The other which I mentioned clinical presentation is after cholecystectomy. 4 to 10% of patients have presented with choledocholithiasis after cholecystectomy, or very rarely they can present after CBD exploration as residual stones. As I mentioned previously, the Charcot's triad, this is a triad of symptoms which is present in acute cholangitis, which is fever, right upper quadrant pain, and jaundice. This makes the triad, and because it leads to biliary sepsis, it can cause hypotension and alter mental status. When these two add up to this, then it becomes Raynaud's pentad, which has five things, but commonly they present as Charcot's triad with fever, right upper quadrant pain, and jaundice. Now, when these clinical features are there, we need to diagnose the cause, and it can be diagnosed by imaging the biliary tract and assessing the output of the biliary tract by liver function tests. So, if we image this tract, it can be imaged by different types of imaging, ultrasound scan, and other things, in which we have to see the diameter of the CBD, and if there is any obstruction here, it will be proximal dilatation of intrahepatic ducts, and if any stones can be visualized. Liver function tests will show raised bilirubin, raised alkaline phosphatase, and raised gamma GT. The imaging techniques which can be used are transabdominal ultrasound scan, endoscopic ultrasound, MRCP, ERCP, and PTC. MRCP is a MRI of cholangiopancreatic ducts. ERCP is the endoscopic retrograde cholangiopancreatography. As we can see here that this is a image of the MRCP which shows gallbladder, cystic duct, and the biliary ducts, and here there are negative shadows indicating stones. This is MRCP. This is only diagnostic. You can only see, but you cannot intervene to do anything. And this is ERCP, endoscopic retrograde cholangiopancreatiogram. Here an endoscope is passed through the esophagus, stomach, duodenum, and from here in a retrograde manner the biliary tract are approached, and this can be diagnostic and therapeutic also. Here is the image when the endoscope is passed here at the opening of bile duct. From here dye is injected and this shows up the biliary tract, and you can see here some stones there. So this is a film of ERCP. So these two tests are gold standard for diagnosis of choledocholithiasis. ERCP has an advantage that it can be therapeutic at the same time. Management. Our objective of management is to treat the infection and relieve the obstruction of the biliary flow. So initially, the immediate steps are taken like IV fluids, parenteral analgesia, and parenteral antibiotics, which usually have to cover gram-negative organisms, and lastly, decompression of biliary tract by ERCP. The definite management can be endoscopic or surgical. Definite management includes cholecystectomy. So we can take an endoscopic approach in which ERCP and cholecystectomy is performed. And the next is surgical approach in which the CBD or common bile duct is explored. You can see here distal to the joint with cystic duct, the supraduodenal part of the CBD is opened, explored, and cleared of any obstruction and stones, and then a T tube is left inside there, which can be used to image later on. And if there are residual stones, this tract from the T tube can be used for percutaneous retrieval of stones. So just to remind you that endoscopic management includes ERCP and cholecystectomy. Surgical management is CBD exploration and cholecystectomy. This can be done by both open and laparoscopic approach. To summarize this, that when you have assessed the patient, if the patient has low likelihood of CBD stone based on the clinical predictors. Then simply laparoscopic cholecystectomy would be the treatment required. If there is intermediate chances of having CBD stones, in which are include raised bilirubin and dilated CBD, then preoperative MRCP should be done to rule out any stones, or cholecystectomy with intraoperative cholangiogram is performed. If it is negative, it does not show any stones, then one can proceed with cholecystectomy. But if there are stone present there, then the patient should either have laparoscopic CBD exploration, or after cholecystectomy they should undergo ERCP. In case of having high likelihood of CBD stones, then we can straight away do preoperative ERCP followed by cholecystectomy. So this is how we should clinically deal with these patients. It is of utmost importance that whenever we are going to do a cholecystectomy, we should check these things, the clinical predictors of likelihood of CBD stones. This can be done by doing an ultrasound scan and liver function tests. This will save you from any post-operative problems. To summarize, choledocholithiasis is a stone present in the biliary tract. They are primary and secondary. Primary are originating in the biliary tract de novo. Secondary stones are coming from the gallbladder. They are investigated by ultrasound scan, ERCP, MRCP, and liver function tests. The endoscopic management is ERCP and cholecystectomy. Surgical management is CBD exploration and cholecystectomy. So this was all about choledocholithiasis, and this will complete our stone disease of biliary tract. And thank you very much till we join again in the next lecture. Thank you and Allah Hafiz.